Hello, everyone. This is Jennifer Hurley speaking. I now have the time as noon Eastern, so would like to start today's webinar from the Physician Leadership Network. Today's topic is patient and family engagement. Your host today is Dr. Adrienne Mims, and your facilitator and team leader, Dr. Mark Massing. We will be hearing success stories from Jen Connor, Mark Marabella, Andrea Goldstein, Heidi Turpin, and we will be listening to presentations from Dr. Jeff Brady and Dr. Judith Hibbard on barriers and gaps. Today's host, Dr. Adrienne Mims. Dr. Mims.
Thank you, Jen, and welcome everybody for joining the conference call today on physician, patient, and family engagement. We're very excited that you're joining with us, and we have a wonderful set of presenters that are going to be joining us today. Just to give you a little background, because I understand that some people are joining this webinar series for the first time today. This webinar series was a development from the Physician Leadership Network, the group of physicians who are involved with the Quality Improvement Organization under our trade association, AHQA, or AQUA, where we realize that there is some value of collaborating across the program regarding the work that we're doing and how we can further enhance patient safety going forward. The first few sessions that we had were presentations dealing with work that we're currently doing in our current 3-year contract. This month, we've branched out to expand the discussion for topics that we are sure will be more of a focus as we move forward, and patient and family engagement is definitely one of those conversations. On the next slide, you see here that I've put up some polling questions. And what we'd like to know is who is on the line participating with us today. It's helpful that we have a variety of people presenting and people who are participating in the call. So we want to know, do you represent CMS? Are you with a QIO? Do you provide support to the providers in the field, or would you happen to be an analyst? Or fill in what the other is if these designations don't fit you. Our goal for these sessions was to have a robust, wide-ranging group of people on the call to make it a richer experience. We also would like for you to fill out the polling question to note how involved you are with patient and family engagement prior to this call. We're sure that from what you'll learn today, that may spur further interest, but we'd like to know just a flavor for those who are on the call going forward. I'll let the polling have a chance to end, and Jen, you can let me know when that's over. Today I'm joining all of you via the telephone rather than the webinar, so I apologize that I'm not able to participate with the chat function, so I will be with the entire line. On the next slide here, this turns us over to our facilitator for today, Dr. Mark Massing. And I'm very proud to have him serve as your facilitator because of his vast range of experience with this topic. Dr. Massing is the Director of Research for the Carolina Center for Medical Excellence, which is the QIOs combined for both North and South Carolina. He's been in this capacity working with the QIOs for 15 years, a lot more than my 4 years, so I value you and appreciate your experience and being willing to share that with us today. His PhD is in epidemiology. For those of you who don't know, epidemiology is the study of patient populations and their health conditions. And my MPH is in epidemiology, so we do have that in common. Mark, thank you for that. But your work really focuses on really what our topic is today. So we're really glad that we have your expertise to lead us going forward. So without further ado, I turn you over to Dr. Mark Massing as our facilitator today.
Well, thank you, Dr. Mims, for those very kind words. And I am very honored to be here, and I would like to extend my thanks to all of the participants and speakers in this webinar today. We think this is a very exciting topic, very important as well. Next slide, please, Jen. I just wanted to give you an overview of today's agenda. Basically, the webinar is divided into three 30-minute sections. In the first 30 minutes, we've invited speakers from 4 QIOs to talk about their successes working in the area of patient engagement. Because of limited time, unfortunately, we've only been able to give them 5 minutes apiece to talk about work that they have been really involved in for probably several years. So I apologize to those speakers for making you squeeze it all into a brief period of time. But our objective here really is to give the participants, all of you participants, an overview of the kinds of work that QIOs are doing and the possibilities for the future. Then for the next 30 minutes, we'll be talking about gaps and barriers. And there we have two prominent speakers with great expertise in the area of patient and family engagement. That would be Dr. Brady from the Agency for Healthcare Research and Quality, or AHRQ, and Dr. Hibbard from Oregon, who will speak to us about much of the work that she's done, and many of you probably are familiar with her work in the area of patient activation and developing measures around that. And finally, we'll conclude in the final 30 minutes with a question and answer session and time for facilitated discussion. This is your opportunity to ask questions of any of the presenters and also to talk about your experiences in the area of patient engagement. And personally, what I'd like to hear from you, since many of you represent QIOs or have some interest in the Medicare Quality Improvement Organization program, I'd like to hear from you what you think QIOs should be doing in the area of patient and family engagement and where we should be going in the future. So your comments along those lines are greatly appreciated. Next slide. There are learning objectives. These are established for your CME, but they also can constitute take-home points, if you will. These are areas that we would like you to focus on and think about, and hopefully you will learn more about as we go through the presentation. So at the end of the presentation today, you should be able to define patient and family engagement, and by that, the definition is very loose. If you look on Google and Google patient engagement, you'll see there are many, many definitions out there, and there's no standard definition. But hopefully you'll be able to get a gestalt of what this is and the overall problem that we're dealing with. And we'd like you to understand why engagement is essential to improve population health. I know in my capacity working for the QIO, I've had the opportunity to conduct physician focus groups around North and South Carolina, and what we're finding is that physicians say that even if the healthcare system was completely perfect, that we would still have 50% of the problems with respect to hospital or unnecessary hospital readmissions. Meaning that a lot of the problems related to readmissions are related to what goes on with patients and what goes on in the community. So the area of patient engagement is absolutely critical if we want to realize the full impact of much of the work that we're doing in the healthcare system. Another objective is to describe some of the successful QIO patient and family engagement programs, and our 4 speakers from the QIO should help you identify that. Understand the barriers, gaps, and challenges related to improving patient engagement. Our 2 speakers in the gaps and barriers section of this webinar will provide information along those lines. And describe some of the tools and resources available or needed to support and evaluate patient engagement programs. There's already been a lot of work done in this area of patient and family engagement. And so all of us interested in going forward, we should all know that we don't need to reinvent the wheel. There's lots of tools out there that can help us. And finally, define the role of the QIO in improving patient and family engagement. And that's where I would like your input as well to help us develop a message and a coordinated approach to what QIOs can do and where we fit into the overall healthcare system, especially in promoting patient and family engagement. Next slide, please. So I'd like to start off with this next section called Success Stories. Here we have 4 QIOs telling us about what they've been doing in this area. And our first faculty member or speaker today is Dr. Jennifer Connor. We're honored to have Dr. Connor here. She has much experience in many areas, and I'm very impressed by the diversity of the areas that she's worked in. Behavioral research, clinical health services research, grant administration, and community-based public health programming and policy evaluation. It's quite a bit of diversity. So she has investigated a broad range of health topics, including childhood obesity. You see it here: respiratory illness, traumatic brain injury, cancer, and birth defects. So I think she's covered just about the gamut of many of the health issues that we face today. So Dr. Connor comes to us from the Arkansas Foundation for Medical Care, the Arkansas QIO, and where now she's working to address cardiac health disparities. So without further ado, I'd like to ask Dr. Connor to join us and begin her presentation. Thank you very much.
Thank you, Mark. Next slide, please. So again, we here in Arkansas have a cardiac disparities special innovation project, and we have really focused our efforts on the Million Hearts campaign, specifically in 5 areas of our state, which have the highest cardiac impact in terms of low socioeconomic status, income, and those kinds of issues. And so really what we wanted to present to you today is some of our community champions. Next slide. Some of our community champions that have really come forth out of the Million Hearts Project. We have here in Arkansas a 4-pronged system approach to implementing Million Hearts, and that's in the healthcare system that is working with clinics and hospitals and pharmacies, and our faith-based system that is working with churches and health ministries and small groups. We have the community system where we're working with community health workers, our hometown health coalitions, our local health departments, and really extending it to barber shops and beauty shops and local libraries. And then we have our municipal system where we're working with the mayors, elected officials, parks and recreations, and the farmers market. So we really have a vast group of people that we're working with the communities. And these 2 individuals who have given us consent to share their story have really come forward to allow us to identify lifestyle barriers that they face. Next slide. So first I want to introduce you to Mr. Lucius Thomas. He's a 36-year-old African-American male. Started out at 355 pounds with a 54-inch waist size, and really, again, lives in the poorest county in Arkansas, and in terms of also health indicators. He travels for work. He's on 28 days and then 28 days on and off of a barge. And he presented with a heart episode, as he calls it. He had an enlarged heart, AFib, severe chest pain, had to be rushed off the barge and into the hospital for a 2-week inpatient stay. Next slide. And so really, this was, as Lucius calls it, a wake-up call for him, and he was lucky to be able to get off the barge. But has really become, again, a community advocate for us and allowed us to use his story to really emphasize that he thought it was over. He said several times he thought it was over after being discharged from the hospital. I'm over the event, and that's it. But the doctor really took it a step further, started discussing dieting, some things they could do, and really instilled in him that she was proud of the work that he was able to accomplish and the steps that he was taking. He reported to us that his wife was very encouraging and his faith was strong, and those were really his motivation, and that his family came first. And so the physician, again, really emphasized the need for him to be around to see his kids graduate. Next slide. So we're happy to report that 5 years later, he is now at 215 pounds. He has a 34-inch waist size. He limits his intake to 1,800 calories. And he works with us to talk about how he breaks down that 1,800 calories. Again, Lucius is, we would say, low literate in terms of understanding what calories meant, what sugar meant, and breads and so forth. He talked about the do's and don'ts and emphasized that there were more don'ts than do's, but that he could work with that. He now runs 4 miles per day and does strength training 3 times a week, and this is his after photo. Next slide. And we'll move on then to Larry Hedrick. He's a 55-year-old Caucasian male coming in at 202 pounds and a 37-inch waist size. He really resides in a suburban area and had some resources, but the commonality here with Mr. Lucius Thomas was that they both travel for work. Mr. Hedrick has a regional sales manager covering 17 states, so he is in his car a lot, traveling over 9 hours for some of his visits. He had a known family history of stroke, diabetes, and cancer. Next slide. And really, he came to us and said this messaging around, I felt fine, nothing was wrong with me, but he did have high blood pressure, high cholesterol, and was trending toward obesity. These were his labs as of November 2012. He was on medication at the time, and you can see that he has very high labs, but we're happy to report, next slide, that he did have a personal relationship, and his physician took a very personal approach. They did discuss eating habits while on the road, which I think is one of the key messages that he has been sharing with us of some of those barriers, and really presented a lifestyle talking about if you do that, then this will happen. So it wasn't a you need to do this, but hey, if you just add 10 minutes a day, we'll probably see X happen. His wife and sons, again, talking about that family engagement, were very encouraging, and it actually changed their eating habits. His wife has also lost some weight as well, and the family really wanted to engage in new activities. They played golf and they played tennis, but they wanted to do other activities, so the family actually took up cycling and started training for a local charity ride. Next slide. Now, 7 months later, he reports in at 162 pounds. He does core exercises, and one of the things that he really emphasized to us was using technology. He uses his iPhone to track his calories, because, again, easy on the road to forget that. And we do see by May 2013 that his labs have gone down. Next slide. So again, one of our lessons learned was really that they both said start somewhere. Start small, start incremental, but make the change. And again, having the messaging show up in the churches and show up in the salons and the areas that they were in, to be able to see, I'm hearing it at church, I'm hearing it in my community, I'm seeing my mayor out walking, and those are just reinforcements really of sustaining the change that they made. I should mention that both of these individuals have now allowed us to tape their success stories. We have video, and we're now using these videos in all of our outreach efforts to really say, hey, I relate to this person, or I relate to that person, again, in the same demographic group, and really the barriers that they often face. As Lucius will tell us, you know, he does push-ups. That doesn't cost anything. It doesn't require any equipment, and it's something that he can do on the barge. Again, Mr. Hedrick will say, hey, I learned how to eat on the road. So those are things about knowing your patient, knowing the barriers that they face, even in their professional lives as well as in their personal lives. Thank you.
Wow, thank you, Dr. Connor. I'm very impressed by some of the improvement that some of the participants in your study made. It's quite impressive. So thank you for telling us about that. The next speaker is Mark Marabella, who comes to us from the Hawaii QIO, from Mountain Pacific Quality Health of Hawaii. And Mark, as with our other speakers, also has some very impressive credentials. He currently operates in the role of a project manager. He's responsible for accomplishing contract preventive and chronic disease management metrics, increasing participation in the PQRS program, the Physician Quality Reporting System, and improving the use of electronic health records for care management. He's also provided technical assistance in the successful development of learning and action networks in Waimanalo. I hope I pronounced that, Mark. If not, please correct me. So thank you for participating, Mark, and let me just say aloha.
Aloha to everybody, too. Thank you very much, Doctor. Paper Prevention is a patient-centered learning and action network which was built from the ground up. Next slide, please. So our goal was to organize a patient-centered learning and action network that would test and assess interventions, try to improve the population health of one of our underserved communities known as Waimanalo. Next slide, please. Our purpose was to create awareness of wellness. A lot of messages out there, not all of them get through, to try and find a way through a focused network that could produce a series of interventions that collectively would make up a program for patient activation. Next slide, please. Our time frame followed the 10th scope of work for the CMS. Basically, we were looking for 12-week sessions, therapeutic lifestyle change interventions, followed by quarterly meetings of stakeholders, providers, and beneficiaries of the Learning in Action Network. The CBA plan would assess the paper prevention interventions, try to refine what worked, introduce new interventions to test. After every 12 weeks and after our meetings, then we'd have new and improved patient programs to roll out after each meeting. Next slide, please. Our target audience was Native Hawaiian and Filipino populations within low income, below the poverty level, that have a history of 2 or more chronic diseases and a high use of health care services. Next slide, please. Our key partners were the beneficiary provider affinity group for the Learning in Action Network, the QIO Mountain Pacific Quality Health, the Federally Qualified Health Center in Waimanalo that serves this community, Pro-Learners, who was an instructional design team, the Department of Health Prevention, and the team and the University of Hawaii School of Public Health. Next slide, please. Our key messages, biggest thing was you matter, okay? And you really do matter, and we're really interested in what you have to say and how you say it, and we're trying to find ways to make therapeutic lifestyle change work for you. We do this through empowering patients and families to advocate for their self-care. Much easier to change as a group than it is to change as an individual, and you have to believe that you can change. Our overall purpose was to get involved to find interventions that work for everybody in our community, to try and create a wellness community, an accountable care community, and discover how we might improve our community's population health. Next slide, please. Overall plan was to try to reduce the degree of generic non-compliance, identify and activate beneficiaries whose therapeutic life change to make a positive difference in their health and also in the economies of healthcare. Next slide, please. Implementation, 2 very distinct populations. One was an independent living area. The other one was a federally qualified health center. The dynamic is very different in both those areas. And the stakeholder affinity group from the Department of Health and the UH School of Public Health developed a logic model and evaluation plan for us, modeling it after the Million Heart Initiative, ABCs, and the CDC cardiovascular health desired outcomes. Next slide, please. Every 12 weeks, the lab collects information on everything from content to delivery and presentation of materials, instructions, design, level of entertainment. If it's not fun, we don't want to do it, neither do they. Retention and sustainability. Next slide, please. Best practices all over the place. Basically, we learn something all the time that isn't all learned, all teach network. The beneficiaries have learned to test interventions and sort of serve as a focus group here. The affinity group providers help shape next version. And we found extra gaming, which is our first step towards lifestyle change. They love the bowl. Next slide, please. Best practices also come that you can ask beneficiaries anything. Be aware of what the response will be. It's a very entertaining group. Sometimes there's not a dry eye in the room, and other times there is such raucous laughter that the people walking by the outside of the room that we're in, they have to poke their head in to see what's actually going on. They have a lot of work, basically, in building friendships. There's a significant factor in using extra gaming for socialization, recruitment, and sustainability. Next slide. We'll reach over 100 people this year. 60 of them will be in and out of the LAN as LAN members. The other 40 are basically people we work with on demonstrations to continue recruitment into the program and help us out. They come from all over the island of Oahu. Next slide, please. Lessons learned after working for a long time on specific things. We found that trying to replace unhealthy habits with healthier ones was a good framework for the seniors we work with, the kapuna as we call them. And so measuring can be a keystone habit. We've also discovered that we need to find ways to introduce self-managed data into the workflow of the patient-provider office visit. You can't ambush a provider in a 15-minute visit with 12 weeks worth of self-managed data. So finding ways to actually introduce that are things that we're still working on. You can nudge beneficiaries out of their comfort zone and provide a structure for them to take the first steps towards managing and advocating for their health. Next slide, please. Our patient-centered LAN has become a safe environment for exploring healthcare from a patient-centered and engaged perspective. Next slide, please. Videotaping is a powerful tool. It allows them to see cognitive and behavioral changes over time. And building a consistent message, we found out this awareness part is the second part of the communication cycle. Finding out how to say that and how to share that really has to preface that message depending on how you want to localize it. Next slide, please. But the biggest lesson we learned is that beneficiaries go from feeling like they're part of the problem, next slide, please, to realizing that they're part of the solution. Next slide, please. Having fun makes the Cardiovascular Health Learning in Action Network experience healthier and happier. And on behalf of our LAN in Hawaii, we want to say thank you, mahalo, for letting us be part of your webinar today.
Wow, thank you very much, Mark. That was a great presentation and nice pictures too. Especially I like the part about trying to integrate self-management data into the physician practice. That's a very interesting topic for me too. Next speaker I'd like to introduce to you Dr. Andrea Goldstein. She's a nurse and she's the Vice President for Medicare Federal Healthcare Assessment at IPRO. She's responsible for the overall management of IPRO's Medicare and federal case review activities. Sounds like a lot of work, including beneficiary and family-centered care and case-based quality improvement. Ms. Goldstein's 29 years with IPRO. She's been involved in numerous internal and external utilization and quality improvement activities, and in the development of staff and consumer education and empowerment programs. She's implemented and managed utilization, quality improvement, and managed care projects for the federal government, for the state, and for local government clients, including CMS and the State of New York Department of Health. Ms. Goldstein is a registered nurse, as I mentioned before. She received a Bachelor's of Arts degrees, magna cum laude from the State University of New York in Albany, and also received a master's degree with a concentration in community health and education from the State University of New York at Stony Brook. So very qualified, and thank you, Ms. Goldstein, for participating. I'll turn it over to you.
And thank you very much for inviting me to participate. I'm very excited to tell you about IPRO's journey. Our journey really begins back in the 9th Statement of Work when we were awarded a Diabetes Disparity Project. Fast forward, and if you move to the next slide, please, to the QIO 10 scope of work, and AIM C6 which is the beneficiary and family-centered care aim. And actually, if you go back in and you look at the statement of work, it really speaks to beneficiary and family engagement and says that it's difficult to obtain the best possible outcome of care without patient engagement because many beneficiaries find it difficult to understand how to access their benefits, navigate the healthcare system, and or select a provider of care. The QIOs are uniquely positioned to promote beneficiary and family-centered care through patient activation efforts that are designed to encourage the use of available quality data and to help shape the future of transparency efforts. And finally, in section C.9.C.10.A, it states that the QIO must offer technical assistance to beneficiaries, providers, physicians, and practitioners. And that statement was the key. Next slide, please. And so what we believe is that AIM C6 of the 10th Statement of Work really afforded us the best of both worlds. It allowed us to serve our provider practitioners, but it also allowed us to provide technical assistance to beneficiaries and their families. And that was really the deciding factor. We made a deliberate decision in the statement of work to divide our activities into serving two customers, the provider practitioner and the beneficiary and their family. And next slide, please. And so what we did is we took the lessons we had learned in the 9th Statement of Work about patient self-management and empowerment, and we devised an activity for the 10th Statement of Work that was based on Medicare beneficiaries and helping them to understand their rights and responsibilities under Medicare. So we offered workshops at convenient community locations. We offered our workshops in English and Spanish. We used Medicare and You as our textbook. And what we did is we incorporated the voice of the patient from our complaints activities and our appeals activities so that our syllabus was never static. If observation was a concern, we talked about observation. If patients had questions about the sign that they saw in the emergency room that talked about EMTALA, we talked about EMTALA. And we also worked to make our program sustainable, offering train-the-trainer sessions to interested community stakeholders, a lot of whom turned out to be representatives from the New York State offices of aging, their area offices. And most importantly, what this allowed us to do was to sustain the synergy and the community relationships that we had built during the 9th Statement of Work, especially in some of our disparate communities where lots of times there really is a gap in terms of how one can navigate the healthcare system. Next slide, please. And so this is just kind of a high-level overview of what our program looks like, but also the components of any self-management and empowerment program really includes group discussion, action planning, that's your empowerment piece, and problem solving. If you think that's all teach, all learn, it really embraces that philosophy. It's not like in the old days when we would go out and do a 60-minute outreach, interrupting a bingo game, something like that. This is a ongoing program similar to the program in Hawaii, where we offered a series of 6-week workshops. The major topics that we spoke about were understanding your Medicare rights, Empowerment, again, how to ask the right questions. What is quality care? What are complaints and appeals? And then promotion of healthy living, working with your healthcare team, how you improve communication, talking about stress management. And also critical to the program is measurement. We looked to measure participant retention and engagement. Knowledge, we used a pre-test and a post-test. Behavior change, did people stick through? Did they come for the 6 weeks? Were they committed? How did they do with their action plan adherence? And also we were looking at our helpline call volume because in talking about the QIO, the complaint process, the appeals process, we were actually looking to see what we increasing the calls to our helpline, looking for assistance and or having questions. Next slide, please. And so while we continue to offer our Medicare patient empowerment workshops as add-ons, it really served as the link to the other activation special projects that we are now engaged in the 10th statement of work. We're very excited. We are working on a 10th statement of work diabetes disparity special project. We were just officially awarded a QIO innovation special project on hypertension self-management. We are just finalizing the award of a dementia caregiver self-management program, and we've set a goal for ourselves that by July 31st, 2014, which is the end of this 10th statement of work, that we plan to have empowered and activated a minimum of 15,400 Medicare beneficiaries and or dual eligibles to self-manage their chronic disease. I want to say thank you and just let you know that my contact information is on the following slide. If anyone has questions, we'd be more than glad to answer them. Thank you.
Wow, thank you very much, Andrea. I like the presentation that addressing the problem in terms of patient empowerment is, I think, very important. Is a very important concept. So thanks again for presenting. Our next and final speaker for the QIO success stories section is Heidi Turpin. And Heidi comes to us with about a one-day notice. The person who was going to speak on this topic suddenly had a personal issue and could not be available. So Heidi steps forth in one day and will present for us here. So thank you very much. So Heidi is with the Texas QIO TMF, and she's been with them since 1980. She has experience as a project resource consultant for health disparities team since August of 2010. She has responsibility for numerous project coordination aspects with this initiative, which focuses on reducing disparities for people with diabetes and increasing diabetes self-management among Hispanics, Native Americans, and African Americans in Texas. So once again, we have a very qualified speaker in the area of patient engagement. Please welcome and thank you, Heidi Turpin.
All right, thank you. And I did want to say, Brenda Ortiz, our program manager, was originally scheduled to speak today, but was unable to attend. So I do want to thank Dr. Messing and Jen Hurley for working with me on such short notice to help me prepare for today's call. Our Health Disparities team in Texas is currently working on its second special innovation project as part of the Everyone with Diabetes Counts initiative. Our first project, entitled Salud por Vida, focused on reaching the Hispanic and Native American populations in Texas with diabetes. That project was actually based on two contracts, both a Medicare and a non-Medicare that ran simultaneously in 2010 to early 2012. The current project, entitled Health for Life, focuses on reaching African American Medicare beneficiaries with diabetes. Next slide, please. Both the Salute Por Vida and the Health for Life initiatives include a component for improving medical management of patients with diabetes by working with primary care physicians. But the real heart and soul of this project is increasing the availability of diabetes self-management education, what we call DSME, for patients with diabetes. Diabetes self-management education empowers patients and their loved ones by teaching them basic skills for managing their diabetes and preventing complications. Classes run anywhere from 4 to 10 weeks in length, but most run about 6 weeks in length. Patients meet weekly for about 2 hours, and they learn about how diabetes affects their body, how to check their blood sugar, importance of exercise and proper nutrition, signs and symptoms of possible complications, the importance of regular checkups and eye exams, and a lot of other important information for managing their diabetes. We have several approved curricula, but I will say that the ones we have found to be most successful are those that are highly interactive and participatory. Next slide, please. So here's a quick look at where we targeted the Salute Por Vida initiative in 2010 to 2012. We focused on those counties with a high number of Hispanic patients with diabetes. By focusing on San Antonio, which is Bexar County there in the middle, the lower Rio Grande Valley, El Paso, and Laredo, we were able to reach about 45% of the Texas Hispanic population. But with those counties, we were only reaching about 11% of the Native American population that was also part of that project. So additionally, we engaged the 3 federally recognized tribes in Texas, which include the Alabama Cushada, the Tigua of Isleta del Sur Pueblo, and the Kickapoo tribe. And we also engaged 2 urban health care centers in both Dallas and Houston that treat Native American patients. We have Native American patients that will travel several hours in other communities to go to Dallas or Houston. Next slide, please. Now I'd like to show you where we are currently targeting our Health for Life initiative. And so you can see it's a very different map. We currently have DSME classes in 28 counties. There are 254 counties in Texas, so that represents about 11% of the total counties. Based on 2010 Medicare claims data, there are a total of about 62,000 African American Medicare bennies with diabetes in Texas, and about 50,000 live in these 28 counties. So you're looking at about 80% of the target population living in about 11% of the counties. Next slide, please. So as you can see from these maps, even when we narrow our target area, we're working with a very large area to reach these patients. To reach communities and to leave something sustainable behind, TMF has worked to find existing DSME programs that can be enhanced or expanded, or create DSME programs where they do not currently exist. In our current project, we found opportunities to expand some DSME programs in the urban areas like Dallas and Houston, but we're finding that Deep East Texas has little to no existing DSME programming available to build from. So much of this area's DSME programming is new to the area. Since DSME is focused on self-management and is not highly clinical in nature, we often utilize community health workers to teach the classes. Community health workers are often seen as trusted members of their community, and we find that they have a lot of success in teaching these very interactive and educational classes. Next slide, please. Before I share some of our results, I wanted to share some of our lessons we've learned along the way. Partnerships are really key to reaching the community, but it's also important to identify the right partners. It's important to find organizations that currently serve the population you're trying to reach. We found particularly with our current projects that organizations that don't already reach out to the particular population you're trying to engage stand a risk of failure by utilizing techniques that's worked for them with non-minority populations. Sort of if we build it, they will come mentality. And they just aren't often prepared to overcome the trust issues that arise when they use the wrong techniques to reach that population. Next slide, please. And I also wanted to share a few lessons learned in marketing for this type of initiative. As I mentioned, trust can often be an issue with populations who experience health and health care disparities. A trusted spokesperson can really help. In our last initiative, Grammy Award winner Tejano singer Little Joe Hernandez was spokesperson for the Salud por Vida initiative. In our current project, we just recently secured NFL Hall of Famer Earl Campbell. For those of you not from Texas, he also was a Heisman Award winner from the University of Texas. He's originally from East Texas, and he's nicknamed the Tyler Rose. He's very well loved, and we're so excited that he's chosen to support our initiative. We also employ very targeted media campaigning, including postering in target communities, mail out to target participants. But ultimately, the best marketing is word of mouth. Because these classes are highly interactive, people tell their friends and family, and our enrollment rapidly increases once word gets out. Next slide, please. So here are some of our outcomes for the Salud por Vida initiative. We had over 11,000 people enroll and almost 9,000 graduate. That's 9,000 more empowered and knowledgeable healthcare consumers out there that now know what they need to do to take better care of themselves and their loved ones. Over half of the non-Medicare and almost two-thirds of the Medicare patients who had never had any kind of diabetes education. Yet the average length of time since their disease was 7.5 years for non-Medicare and 13.5 years for Medicare. So for Medicare patients, almost two-thirds never had any kind of education and have had the disease for over 13 years on average. But the real success story isn't in the numbers, but as in any patient-family engagement initiative, it's the individual stories. In fact, I wanted to share a quick story I just heard about yesterday. Our staff CDE, Ms. Artis Reed, attended a BSME class being held by one of our community health workers to observe and provide her feedback. After the class, a gentleman from the group came up to Artis and said he wanted to brag about his educator. In one of the earlier classes, they discussed foot care, how to check sensation in the foot, how to examine the foot, how to identify warning signs. The gentleman went home and checked his feet with a mirror. Indeed, he did find something on the bottom of one of his feet that he thought was concerning. He'd never felt it and didn't know there was a problem. He went to his doctor, and his doctor told him it was a good thing he'd come in. He was told that if he waited much longer, he would have likely had to have his foot amputated. This just shows how small changes a patient makes today can have large and lasting effect on their future health and well-being. Last slide, please. So just in closing, thank you for your time and attention. Here's my contact information. I believe there are some handouts that go into more detail about the initiative, but Brenda Ortiz and I are always happy to speak with you if you want to know more about the initiative, so feel free to call us on our 800 number. Thank you very much.
Thank you, Ms. Turpin, for stepping out and speaking on behalf of Brenda. We're very happy to get this presentation. Next section, we'd like to spend some time talking about barriers and gaps related to patient engagement. What kinds of barriers do we run into in our attempts to improve patient engagement, and what gaps need to be filled? We have two very qualified and well-known speakers in this area who have kindly consented to share some of their experiences with us. Our first speaker in this section is Dr. Paul Jeffrey Brady, who is an Associate Director of the ARC Center for Quality Improvement and Patient Safety. ARC, most of us probably know as the Agency for Healthcare Research and Quality. They drive much of the quality improvement projects that we see nationwide. Dr. Brady leads ARC's patient safety portfolio, and his primary responsibilities include oversight and coordination of agency-supported patient safety-related activities. The Patient Safety Research Portfolio funds projects covering a variety of topics such as teamwork in healthcare, healthcare-associated infections, and medical simulation. Dr. Brady has lots of experiences and background. He's a captain also in the United States Public Health Service. Previously, he's been a clinical reviewer for the Food and Drug Administration, Office of Vaccines, and finally, he's held positions as a medical epidemiologist with the Department of Defense, and he's primary care physician in the U.S. Navy. So, Dr. Brady, I don't know how you have time to do all those things, but thank you so much for participating in our conference, and I'll turn this over to you.
Thank you very much, Dr. Massing. It's really a privilege to be with you today, and I'll just say, personally, as a public health physician, it's very encouraging for me to hear the stories that have been talked about today. I think the examples were certainly well chosen, and I'll just say that probably my participation, but the thing I'll remember most about today is the good work that's happening throughout the country. It's again just really encouraging the dramatic impact that those projects represent. Well, today I'm going to talk to you, give you a very brief overview of a project that certainly addresses this important topic of patient and family engagement. There's a fair amount of excitement and interest about the project and the product that it produced that I'll be describing today. And I think that is really just a testimony to the important niche that this topic holds in its relationship to all of the work we do. And by that I mean the bigger we throughout the country in trying to improve the quality of healthcare throughout. I think patient and family engagement is relatively an untapped area. The things we've heard about today are certainly exceptions to that point. But anyway, I'll tell you more about what ARC has been doing in this area. So next slide, please. I'd like to start off by telling you a little bit about why ARC chose to fund this work. We actually started thinking about the idea for this project sometime in early 2009. And at that time, there was a lot of interest in patient and family-centered care. We found a fair amount of papers, guides, toolkits, and other resources that were aimed at increasing patient and family-centered care. And those resources were certainly a great start to engaging patients and families in their care. But we determined through our planning processes that more was needed in order to establish the active engagement of patients and families in their care as a nationwide norm. We chose to focus on the hospital setting as a manageable initial step toward that goal. And again, I'll tell you more about the project here. Next slide, please. I want to just first mention a lot of the barriers that have been touched on today, the barriers that we were specifically interested in with respect to this project, again, because it is hospital-focused. The barriers are themselves hospital-focused. But again, patient and family barriers in general are certainly something that we all deal with in whatever the approach we're taking to improve healthcare quality. Certainly patient and family engagement is no exception. As part of our early planning for the project, we considered several barriers that seemed significant, and those included many things that are, again, common to all quality improvement efforts. Competing priorities, often in the face of limited hospital resources, I think probably always in the face of limited resources. In some cases, not always, but in some cases, hospital cultures are not conducive to patient and family engagement and some of the changes that really can be helpful. Furthermore, provider and patient and family experiences and attitudes themselves can interfere with effective engagement. Health literacy, we've heard some examples of that today, and it certainly plays a role with engagement in the hospital setting specifically. And then finally, I think what really pushed us to move forward with this project was a lack of how-to resources that hospitals could use to effectively consider, plan, and implement programs to improve patient engagement. Next slide, please. I want to just recognize the project team that was pulled together for this project. AIR was the prime contractor, and one of their major strengths was the phenomenal team that they did, in fact, pull together. It included an impressive list of folks from organizations that you see on the slide here, and in addition to leaders in the field that came from these organizations, others with expertise in patient and family engagement, that we had the benefit of their input, consultants like Shoshana Sofair, Dr. Tony Slonim, along with probably some of the most compelling input that came from patient representatives themselves. All of these groups really made just valuable contributions that are represented throughout the end result. We really couldn't have asked for a better group of advisors. Next slide, please. I don't want to go into this in any great detail, but this just sort of characterizes sort of the whole development of the project all the way up through testing. We started with an environmental scan, which I'll say a little bit more about in a second. We drafted the guide itself and tested the materials fairly extensively. Those were developed initially with the benefit of different strategies, including cognitive interviews. We made good use of focus groups for various purposes. And then all of that was, again, a very active process, revision of the materials and other activities to just try to make what we were putting out a better product, again, all based on the evidence. So the fully finished guide became available earlier this month, at the beginning of July. And as you can see, the timeline shows the steering group for the project that I described advised the project team at many key points along the way. We've had 3 formal meetings in the first year, and then a couple of times throughout in addition to that. And then as needed, they were available for specific consultation based on their expertise. So again, my involvement in the project was not as much as I would like for it to be because of other responsibilities. But when I had an opportunity to engage with this group, I was just so impressed with their commitment to the project, and that definitely translated into what I think is a good end result. So the next slide, please. I mentioned the environmental scan. This really, established the foundation for the guide itself. Here you can see some details about the environmental scan. We abstracted some 181 articles related to the topic, and those included some key informant interviews to make sure we were including seminal research in the area. More than 100 websites, various, as I mentioned already, existing tools that promote engagement, and we conducted some usability assessment of about 80 of those tools, and collected and reviewed documents from hospitals, things like policies, et cetera. And then another good source of information were the key informant interviews with 20 hospital leaders on this topic specifically. And our steering group, again, as I mentioned, provides valuable input throughout the development of the environmental scan. Next slide, please. So just a very high-level overview of the findings from the scan itself. Again, this is the foundational document on which the ultimate product was based. It's very rich, lots of information. It's about 100 pages long, and I would encourage those of you who haven't had an opportunity to see it, if you have the time to dive deep into that resource. Some high-level findings: we found a lack of tools that focus on what's important from the patient's perspective. More often there were tools that were available that reflected what healthcare professionals think are important. Certainly that's an important consideration, but the patient's, perspective was not as well represented as healthcare professionals. Many of the system-level tools don't have tools at the individual level to support the system-level initiatives. So, for example, they may have tools to advise hospital employees on how to develop an advisory council that would include patients, but there aren't really sort of corresponding tools to help patients and families know how to develop organizational partnership skills that are necessary for that membership and that participation to be sort of effective and actually make a difference. So trying to take it to the next level, if you will, in terms of not only having people at the table, but having them engaged in a way that they're actually contributing. Another specific finding was that the tools lacked concrete action steps that patients and families could take. The materials may instruct, for example, patients to ask questions, but not really help them by providing them with some specific action steps that would show things like what are the kinds of questions you need to be thinking about, or that might apply to your specific clinical situation. What's the right timing, and what's the best situation in which to ask questions, and what are some that are maybe not as good? Just to sort of, again, try to sync up the expectations and knowledge and the practices of patients with that of providers. And then finally, this is sort of the theme that I've already touched on, but a lack of complementary materials. That was, I think, one of the more interesting findings and really served as a primary structural component for the guide. And so this was, something that I think you'll find throughout the guide if you haven't seen it yet. So next slide, please. Some important principles in the guide on which it's based, some principles on which it's based. Since we wanted the guide to highlight in meaningful ways that patients and families can help improve quality and safety, the strategies that we chose were selected based on their potential for significant impact in that regard. So we wanted to share partnerships between patients and families, hospitals, and healthcare providers around the same set of shared goals. Again, this idea of complementary materials. Each strategy has educational tools and materials for patients and families, training for healthcare professionals, those are part of the tools within the guide, and information and examples about how to describe and how to execute strategies in the real world. We wanted strategies that promote behavior changes that can lead to a change in the hospital's culture with respect to this topic of patient and family engagement. And we also, another guiding principle for the development of the resource was that there would be a sufficient range of tools so that all hospitals, either those with lots of experience with this topic of patient and family engagement, or those with relatively less experience, would still, all of those groups across that range, that spectrum, would find tools that would be useful. So that was a big challenge, but I think we accomplished that to some degree. It's important, certainly the basis of our agency is to produce evidence-based resources and information. So that was clearly an important goal for the guide, and thus the environmental scan that I mentioned, and it's the rigor of that component of the project. And then finally, feasibility was clearly a key. And one example of how this particular principle guided our development was that bedside rounds were discussed as a potential strategy for inclusion, but ultimately the project team settled on nursing bedside change of shift report as something that they thought would be a little bit easier for hospitals to implement as an initial step. Bedside rounds might be more appropriate for a hospital that has a more advanced kind of experience in this range. So that just gives you an idea of the detailed nature with which the team, I think, considered what would be included and how those decisions were made. Next slide, please. So this just really summarizes what I've mentioned before about the process for developing the guide materials. Some of the quantitative information that goes along with this. There were 4 focus groups with patients and families, in excess of 30 interviews with patients and families, and then 30 more with healthcare providers. Hospital leaders, as I mentioned, were interviewed. And then we had the benefit of Patient and Family Advisory Council review of materials. And then for about 20% of the guide materials, we revised those and had the benefit of another round of testing. Next slide, please. So this really, in a nutshell, summarizes the content of the guide. We originally planned to combine existing tools with new tools, but since, again, as I've said, there was a lack of complementary tools, we ended up kind of starting from scratch, essentially. In many cases, we built on what was available, but developed tools in a novel way so that they would really represent this paired, kind of shared, complementary perspective. We chose to go more into depth on particular topics rather than try to cover a broader range of topics. So that's the explanation for the 4 strategies that you see here, and not more strategies, say 6 or 12 or however many that we could have selected. And so what you see here are the strategies themselves. Looking at strategy 1, we suggest several different ways that hospitals can work with patients and families as advisors. For those new to this idea, they might want to start with working on advisors on an occasional basis on a specific kind of more concrete issue. For example, hospital signage, something that might be a little bit easier to work through. Wayfinding within a hospital, was it easy to sort of find your way around, and how did that come across to a patient? But other more challenging issues, certainly the guide lays out how selection of issues is definitely an important consideration, especially for those new to this process of having patients and families on these advisory committees. Strategy 2 looks at how to improve communication through various strategies, and so that's a nice summary of communication in general, but also specific to patient and family. I've already mentioned that change of shift report. That's the strategy 3, and lots of helpful resources in there, including things like as specific as presentations about how to roll this out, how a hospital champion might roll this out to a staff that that's new to this kind of an approach to patient care. So that's in strategy 3. And then strategy 4 tackles a very common challenge that we all are familiar with, and that's the discharge. And the team developed an acronym to sort of try to organize the different aspects of the discharge. IDEAL stands for including the patient, discussing the D with 5 key areas to prevent problems at home, educating the patient in language that's appropriate to their level of understanding, assessment of how well clinicians explain information by using TeachBack, and then listening. And I should point out that these, while they were developed for this project, they certainly made use of existing information from leaders in this area, such as Brian Jack, Eric Coleman, who've all developed tools and resources specific to this problem. So this, by no means, did this project did not consider those. It was definitely, those are rolled into that strategy. So next slide, please. I want to tell you a little bit about the implementation and the testing. These are the 3 hospitals that implemented the guide as part of the evaluation. A lot of thought went into the selection of the hospitals. We wanted diversity in terms of their geographic location, bed size, academic versus community hospital patient population. I think we achieved that fairly well. I think I probably won't say, in the interest of time, a whole lot more about these projects, about these sites on this slide in particular, but they were very engaged, and I think their involvement certainly has enabled the production of a stronger tool. On the next slide, you can see the implementation and the specific strategies that each site shows. So you can move to the next slide. Thank you. So Advocate Trinity chose to employ all 4 strategies. And then you can see what Anne Arundel and Patewood locations with those implementation sites, which strategies they chose. So this just sort of makes the point that there's lots of flexibility within the guide in terms of how much or how little different organizations chose to use. And I think, again, that flexibility is represented in the tool. Finally, I won't go into the next slide, please. I won't go into any great detail here, but this just sort of for those who are interested in the research methods underlying the development of the guide, this provides a nice summary overview of what different strategies and approaches were applied. It was a mixed methods pre- and post-evaluation, and again, all of this was focused on ultimately producing a tool and a resource that would meet the original aims and objectives of the project. So the next slide summarizes our evaluation findings and outcomes. I think I'll just say briefly a little bit about each of these. So for the HCAHPS scores, those showed a definite trend upward, particularly in the domains of communication, pain management, and discharge. And I'll say on this point and also on others that these kinds of principles are also represented in the product itself. So in other words, specifically, hospitals in their overall mission and strategic objectives that they have for the entire system, we tried to draw direct connections between how this particular activity not only can but should be connected in a very real and sort of substantial way to other goals that the hospital may have. So the HCAHPS scores is one example of that. The second evaluation finding is that patient and families noted the benefits associated with implementation of the bedside strategies, including improved staff responsiveness, improved communication, and better information sharing. Another finding, nurses reported that the bedside change of shift was time neutral or safe in time because it was a more focused assessment on the patient. And this was an interesting thing I thought. It decreased opportunities for chatter among nurses, so I think it helped them to be a little bit more focused in their work, at least in that phase of their work. Nurses also reported that the bedside shift report increased accountability between outgoing and incoming nurses, which was viewed as a significant benefit by both unit-level managers and frontline staff. Finally, nurses indicated that the bedside strategies improved information sharing and communication with patients and families and contributed to positive patient experience of care. And then there were some staff survey findings otherwise that were also quite compelling. So with that, I'll stop, and I guess we'll have questions and discussion at the end.
Thank you, Dr. Brady, for taking some time to tell us what you've been doing at ARC. It's very informative. I know we're running a little bit short on time, so I want to introduce to you right away our next speaker, Dr. Judith Hibbard. For those of you who have been involved in the area of patient engagement, you know that Dr. Hibbard is one of the leading experts in the country in this area. She's a senior researcher and professor emerita at the University of Oregon, and she's worked in the area for more than 30 years in the area of consumer research and choice and consumer choices and behavior in healthcare. She's a lead author of the patient activation method, and many of us have been looking at that at this point. The patient activation method measures an individual's knowledge and skill for self-management. So it's a very interesting measure and tool that we should all be aware of. Dr. Hibbard advises many healthcare organizations and initiatives around the country in the area of patient engagement, and her credentials are all listed here on this slide, and I will try to save time by not reading them off other than to say it's all very impressive. So Dr. Hibbard, sorry to shortchange you on the introduction, but we will pass it on to you and let you begin the presentation.
Great. Thank you so much. Today what I want to talk about is the patient activation measure, and but I do want to say that I do have a financial relationship with Insignia Health. My comments today will just be on the research and what we've learned as the application of the research findings. Let's go to the first slide. So really what I'm going to share with you today is what we've learned as a result of being able to measure this idea of patient activation, and how it can help us overcome some of the barriers that have been already discussed today, and what approaches are helping patients to become more activated or engaged. And many of you have already talked about some very effective strategies, and I will expand on that. And then I'll talk a little bit about how measurement is being used to improve care and reduce costs. Let's go to the next slide. So the definition that we use of what is it mean to be activated is that an individual does have the knowledge, the skill, and the confidence to manage their health and their health care. And individuals who are more activated understand what their role is in the care process and essentially feel able to take that on. We know that this varies considerably by in any population group, even when you look within, for example, a low-income clinic, you will still see patients who are highly activated and patients who are very passive. And that's one of the reasons that it's important to measure, because it's important to know the issues that the patient in front of you has. So let's go to the next slide. This is just what the questions are. They're very general. And there is a measure now that's just 10 items, and that's what you're looking at here. The measure itself was developed using Roche analysis, and that creates a stronger measurement than most social science-based measures. It creates something called a latent construct, which means that it's measuring one basic idea. The statistics don't tell us what that basic idea is, but we think what it's measuring is a patient's self-concept as a manager of their health. And that self-concept may not even be conscious on their part. And that's why we are seeing that it's related to almost all health behaviors and many health outcomes. We can go to the next slide. So our task today is why are patients disengaged and kind of what can we do about that? And from our research where we've done in-depth interviews with people who measure low on the scale, and particularly patients with chronic illness, what we've learned is that people who measure low on the scale feel overwhelmed with the task of managing their health. They maybe have had a lot of experience with failure in trying to manage. They have low confidence. They have limited problem-solving skills. And they may not understand what their role is in the care process. So these are the issues that we try to address with patients when we know that they are measuring low on the scale. Let's go to the next slide. So we've identified that there are kind of 4 levels that people go through on their way to becoming effective self-managers. And so sort of reviewed for you what is going on with the least activated group there. But I want you to just think for a minute about what this feels like from a patient's point of view. You are a patient who is less engaged or less activated, and you go in to see your primary care doctor. And if you have chronic illness, you may be given a big, long list of things that you're supposed to change about your life. But for somebody who is overwhelmed and who doesn't have much confidence, the likely outcome of that, even if you did try, is that you aren't going to be able to make those kinds of changes all at once. And kind of the human response to that is when you can't do it all, to do none of it. So in a sense, by not really understanding where a patient is, we are often setting people up for failure. And what we really need to do is set them up for success. Let's go to the next slide. So the measure's been out there for a while, and it's being used by researchers all over the world, and we're learning from them. It's a very advantageous situation because we can learn about different patient groups and different interventions. And there are at least 100 published studies now that use our measure to understand different populations and different interventions. And I'm just going to review this very quickly because there's really a lot there. We have 2 articles in the February Health Affairs which summarizes this research. But basically, higher activated individuals are more likely to engage in positive health behaviors, from prevention to healthy behaviors to self-management and disease-specific behaviors. They're also more likely to have better health indicators and health outcomes, lower utilization, particularly lower utilization of costly utilization such as hospitalization and emergency department use, and overall lower cost. So there is a lot of advantage to having more people be more activated, feel more control, feel more in charge of their health. We also know that activation is also linked to better care experiences, which I don't have time to talk about today, but we have an article that's out in Health Affairs this month that talks about this. Let's go to the next slide. So just to give you a little sampling of this, we developed these behavior maps for different behavioral domains. And this is just one of many, but it shows you a picture that is pretty consistent across different behavioral domains. This is measuring, this domain is managing hypertension. And we look at what percentage of people in each level of activation actually do these behaviors. And as you see, and this is the out of this, is that as behaviors become more difficult, require more action, or require people to be more assertive, fewer people in all the levels of activation actually do them. But we still see this kind of stair-stepped approach where the higher activated patients are the more likely ones to be engaging in that behavior. So let's go to the next one. But what we took away from that is that a lot of what we're asking people to do are really only done by the higher activated patients. And maybe by focusing initially on more complex and difficult behaviors, we may be discouraging people who are less activated. So the insight that we took away from that is we know that people who are less activated have very low confidence. And how do people get confidence? Probably the most powerful way is to experience success. So the strategies that we've developed are to set people up for success. So for people who are less activated, we start with smaller steps. We give them permission not to do everything on their big long list right now, but focus on one thing. And since we want people to take ownership, we encourage them to move on a behavior that they want to do, that's important to them. So, but break that down into smaller steps. And what we've observed is that when people do start to experience a little bit of success, even with these very small steps, their motivation increases. And they start to feel like, well, maybe I can do this. And we've also observed that as people move up the scale, they change multiple behaviors. We've observed this, that as activation increases, multiple behaviors change, which makes sense as people feel more in control. They change multiple things about their lives, just like we saw in the examples of these success stories. Okay, let's go to the next slide. So one of the other insights we got was when we offer different programs and we offer services, who shows up tends to be the higher activated among any population. We saw this with the Stanford Chronic Disease Self-Management Program. We saw it also with the use of patient portal in a large delivery system. So if we don't know about our population, we may think, okay, we're doing a great job, but we may be missing that more passive end of this dimension. So let's go to the next slide. But we do know that this is the good news, that targeted interventions can increase patient activation. And some of your success stories utilize these kinds of interventions like peer support, increasing patient skills. And the one that we have found most effective is tailoring support to the individual's level of activation. That is, for low activated patients, start small and encourage small steps. But the best news is that when we have seen these interventions work, the least activated patients make the most gains when they are appropriately supported. And that is very exciting, that there is approaches that we can use here that are going to make a difference. Can go to the next slide. I'm not going to go into much detail here. It's just a representation of the strategies that we use at each level of activation. But at the lowest level, we think about it as building a foundation of skills of mindfulness, of understanding how your behavior is affecting your health, and very small behavioral steps. Think about it as learning to swim. People, when they learn to swim, it's not the best strategy to throw them into the deep end of the pool. But in healthcare, that's kind of our main strategy. So we want to help people gain a little bit of confidence, put their face in the water before we ask them to float, before we ask them to do laps. And that's the overall kind of the big picture here. Okay, let's get to the next slide. Hospitals are using this to tailor how they support patients, and by having more follow-up with patients who are less activated. I think we'll just go on to the last slide here because we're running out of time. So basically, by measuring, we can help patients. We can really meet them where they are. We can improve efficiencies by reaching out to people who need more support, and we can improve the quality of a medical encounter by really understanding patients better. So this can be a key to improvement. And I'll stop there. I know we're out of time. So thank you.
Thank you, Dr. Go ahead. Thank you, Dr. Hippert. I think